Good afternoon. Welcome to Fairmount Presbyterian Church and to this William Birkett Williams Memorial Lecture. I'm Ryan Wallace. I am the senior pastor here at Fairmount, and I just arrived here at Fairmount a couple months ago, of course, and so this is my very first William Birkett Williams lecture. But let me say that I'm so very grateful for this legacy and this remarkable tradition. I just heard this is the 53rd lecture in the series. And what a privilege it is to hear some amazing thinkers and practitioners, true geniuses and experts in their respective fields. And when I heard that we'd be hosting Dr. Gordon today, I was ecstatic. For centuries, the church has had an unhealthy relationship with science, and that's the church's fault. It's time for us to change that. It's time for churches to embrace the role of science in helping us understand our minds and our bodies and our planet and our universe and everything in between. And in fact, I believe that so strongly that a few years ago I taught a 6-week course on faith and science that I called Quantum Jesus. That's right. We explored topics at the intersection of faith and scientific advance like quantum physics and CRISPR, genetic engineering technology, and all kinds of things to try to understand how science can shed light on our theology in a new way. And I really believe that the church needs to see science as a partner and not as a threat. Science reveals new information to us every day, and it's true that some of that information will change our theology. It will change the way we think about God. But I believe that God is working through scientists to help us better understand creation and God's presence in the fabric of our universe. So before I hand things over to the chair, Karen Dakin, to share more about this lecture series and this fund, please join me in an opening prayer. God of the cosmos, God of all creation, we gather here in this space so that you might be revealed to us in new ways, that we might see you in the way that our world works, and that we might be called in new ways to help make this world whole, to help heal people, to help stop people from getting sick and dying when we have the tools to do so. Bless this time. Help us to feel the presence of your Spirit moving between us and among us. We pray this in your holy name. Amen.
Thank you, Pastor Ryan, for your warm welcome. I am Karen Dakin, and I chair the William Birkett Williams Memorial Lecture Committee. William Birkett Williams was a first lieutenant who served as a fighter pilot in the U.S. Air Force and was lost in action in Libya on January 11, 1943. His parents, Birkett and Edna, established a lecture fund at Fairmount Presbyterian Church to serve as a memorial to their son. The first lecture was held in 1952, and today Dr. Stephen Gordon will present the 53rd lecture in this series. There will be a Q&A opportunity. If you are watching online, please send your questions through the YouTube channel, specifically the Q&A chat on the YouTube channel. And now, Dr. David Bosler will introduce his colleague and his friend, Dr. Gordon.
Good afternoon, everyone. Thanks, Karen. As Karen said, I'm Dave Bosler. I am a member and elder here at Fairmount Presbyterian Church, and it is my distinct pleasure to introduce this afternoon's speaker, Dr. Steve Gordon. Dr. Gordon is Department Chair of Infectious Diseases at Cleveland Clinic. His background is that he earned his MD at Cornell University, completing an internship and residency at University of Chicago, infectious disease fellowship at Emory. Additionally, he's completed a fellowship at the Centers for Disease Control's Hospital Infections Program, where he served as an epidemic intelligence officer. Dr. Gordon's been appointed to the Defense Health Board, which is a federal advisory committee to the U.S. Secretary of Defense, and he's previously served as president of the Society of Healthcare Epidemiology. He's published over 160 articles and multiple book chapters. I've known Dr. Gordon peripherally as a colleague for several years, as our paths crossed occasionally during our mutual tenure at Cleveland Clinic. But it's really been over the past few years that I've worked a little bit more closely with him, as many of our roles and the teams that we work with have evolved and grown and adapted to meet the challenges of patient care and care for our community in the face of the pandemic. My role, for those who are unfamiliar, is in laboratory medicine. Most recently as chair of the Department of Laboratory Medicine, which is the department that includes the laboratories where both the COVID qualitative PCR testing is done and where the SARS-CoV-2 whole viral genome sequencing for the Ohio Department of Health's variant surveillance program are done. Microbiology is not my specialty by any means. And although I thought I'd left behind the chance to help with a response to a pandemic or to work in public health after I chose pathology as a specialty and then subsequently specialized in leukemias and lymphomas, it was really all hands on deck during the pandemic. So I, like many others, took on new and previously unexpected roles. And it's in that context that I worked more closely with Dr. Gordon, gotten to know him a bit better. One aside for a moment, I have learned a lot about the benefits of working closely in teams, in cross-functional teams, both in the healthcare and in the public health spheres, and how important it is, how much it improves the agility and the quality of solutions when we work together. And I think that's a bit of a, if you will, silver lining of the pandemic, recognition of the value of working together in teams in coordinated fashion. So although I was adapting to new roles during the time of the pandemic, Dr. Gordon's expertise, experience, and communication skills were really tailor-made for a pivotal role in the pandemic. He's been the resource within Cleveland Clinic that physicians and really the entire organization look to for the most up-to-date and accurate information, which is crucial to our ability to do a variety of things, not just patient care, which of course is very important. It's very important for us to provide care for our patients, but also the settings in which we provide that care in a safe way. Lots of guidelines for caregivers and really for the organization as a whole. Dr. Gordon's also been a consistent and trusted source of expertise for our community during this time, with numerous media appearances discussing everything from pathophysiology of COVID to modes of transmission, therapeutic approaches, and immune evasion, among other things. So when Karin approached me about this topic for the William Birkett Williams lecture series and sought ideas about who might speak, there was really one person who came to mind immediately. And thankfully for all of us, it's worked out that he's able to join us here this afternoon. So I'm very excited to hear his expert take on the impact of the pandemic, the lessons learned, and how to prepare ourselves for the next time. So please welcome Dr. Steve Gordon.
Wow. It's truly an honor to be here, and I appreciate the wonderful introduction. As I looked at the prior speakers, we joked, or not joked, but I think I'm going to be the weakest link of the lineup. But Pastor Ryan, Ms. Dakin, and Dr. Bosler, it is just great to be here, and I appreciate everyone's attention and sacrificing a little time on a beautiful Sunday in Cleveland, one of our first, obviously, of the season. My tasking as we move forward is going to give you my perspectives, and I have no financial disclosures, but I do have a disclosure. Of course, I'm bringing my unconscious bias. It's been about 2 years. I function primarily also as a clinician, a little bit of an investigator, And as David said, obviously a lot of issues in terms of advising the executive team in terms of our teams, in terms of moving through this pandemic, which has really been a journey for all of us. You know, one thing I read, which I think is true, is that although all of us have experienced the pandemic, each one of our experience is unique, and all of us, I think, have learned and can share and help in terms of, even if we've lost loved ones, but moving forward, and hopefully, as we said, the lessons will be here, is that we'll be better prepared for the challenges in the future. So with that, in the next 30 or 40 minutes or so, I'll give a brief outline, try not to get too technical, a little bit about my lessons learned. We'll talk briefly about vaccinations, then talk about the preparedness and also some of the disruptions that we've all seen, not just in healthcare, but in our lives. Some of those, I think, are what I'd say silver linings, so to speak, in some maybe less so. As I was educated, I couldn't find much online, but I do want to acknowledge for all of our people in combat that protect the homeland here, thanking them for the service. And obviously, William Birkett Williams paid the ultimate sacrifice. So I know we have many men and women now in the armed forces in terms of protecting the homeland here throughout. And again, as our president always reminds us, we wish them Godspeed. The other giant, I think, someone whom I was able to meet once, and many of you may have known through novels that we lost in February, was Paul Farmer. Just an interesting man in many ways. I think the Hebrew words tikkun olam, that is to heal the earth, is really probably embodied by Dr. Farmer, who died in his sleep in Rwanda, where he was taking care of, again, people of deserving. So he at CDC and others was kind of our, just an amazing person, and again, did not die of COVID, but his death really impacts many of us here in healthcare. And that's another reminder for me of another kind of William Osler, Canadian, but obviously a little bit of a connection there. Barney Crowell, and many people actually knew him well. And in World War I, Osler lost his son. His son was mortally wounded on the battlefield. It was people like Barney Crowell and a couple other colleagues that could not save him. But it's that team spirit out of World War I in teams that actually is what the clinic and other great universities like Case are built upon, as Dr. Bosler mentioned. But Osler was also, he always took that 20 minutes at the end of the day to read, so very well read. And I do like this quote: "Humanity has but three great enemies, fever, famine, and war. And of these, by far the greatest, by far the most terrible is fever." Now, I know I'm a little biased as an infectious disease practitioner, but we see these things ongoing, conflict, which can drive both outbreaks and also famine. I do want to say one of the things that we learned is our knowledge, as you know, does not come out of thin air. It's based on a lot of work. And one thing we're going to see in COVID and coronavirus is women scientists. And if you go back and look, actually, it was a woman scientist who first looked under the electron microscope and saw the knobs, or the corona, the crown of this virus from which it got its name. And so when we talk about the disease, we talk about COVID. When we talk about the virus, we talk about SARS-CoV-2 to distinguish it from other coronaviruses. We won't get into too much of the molecular biology, but I think all of you understand it's a virus. It's by definition then a pathogen. It parasitizes not just human cells, but in particular human cells. And it's a relatively large RNA virus with its genome around 20 to 30,000 base pairs. And it's not as mutating as other viruses that we can see RNA, such as HIV, but it does mutate 1 to 2 times a month in terms of its base pairs. And this obviously can have some implications. But the spikes on the outside, those corona that she saw, are not only important in its pathogenesis, that's how it attaches to the cell, but it's also important in therapeutics and designing, say, vaccines. That's the S-spike protein target, and also for some of our drugs and for some of the mRNA vaccine platforms. The other thing, all of us listen to podcasts. One of mine is the Merriam-Webster's kind of words to try to make up for some of my lack of taking too many English courses, more science courses. But, we have new words in 2021 linked to the pandemic. And as reminded me in the Webster's, it's not necessarily that they're new words to English, but they've reached a threshold of use in the population that now is deserving to get into the dictionary. So breakthrough, like breakthrough infection, long COVID, super spreader as an event, vaccine passport, vaccine hesitancy. So this really reflects a lot of the conversations that we see in the population, and I think that that's a nice way of also measuring the impact of the pandemic. Now, in this slide, I summarize why was such a relatively small virus, seemingly come out of the blue, why was it and has it been so hard to control for the world? This is obviously not just a U.S. problem, it's a global problem. And I broke it down into 5 big components. Some may be more important than others. The first is, this is truly a novel virus, meaning there was no pre-existing immunity that any of us had once it made the jump from a intermediate mammal, which is still to be determined, its origin is in bats, but to humans. And without that pre-existing immunity, all primary infections can tend to be worse, and therefore everyone potentially at risk for infection. Transmission without symptoms. Most of us are taught, right, as we're little, if you've got a cold or a cough, cover it, but if you're feeling flu-like, stay home because you might transmit to others. The fact that, as we'll see, that in contrast to influenza, which may have a day or so of being able to transmit without symptoms, with COVID-19, it could be up to 2 to 3 days. So a good part of the transmission is already occurred by the time I lose my smell or develop a cough or a cold. And that is one of the keys to why it can transmit so readily. The other is the non-respiratory clinical symptoms. And this early on, if you think back, this was a pneumonia or a flu-like illness out of China. That's how it was billed. And that's where we were targeting initially. And we then recognized there were other presentations. So the loss of smell, which is not specific to COVID, but again, it was a harbinger in terms of this nature. Many of you might have heard about the chilblains or the COVID toes, or sometimes the GI, or sometimes fuzziness. So although the primary presentation is still flu-like, there were many other clinical presentations that can occur that weren't recognized early on. Globalization. We talked about this earlier. So this is a key factor in transmission. It's also a key factor in policy that we do need to care about. If there's an outbreak of X disease in North Korea, no matter how we feel about them politically, there's no such thing as Fortress America. And if we remember back, and I remember at the meetings when we stood up the command and control at the clinic, it was always about taking histories based on travel. And that was probably a big mistake by us, because if you look at Guangdong, in terms of in Hunan, these cities are 20 million people with big airports in terms of this. So by the time the Chinese published that first report, which came out like January 1st of 2020, of about 80 hospitalized patients, we should have already known, because of intercontinental travel, that there were potential cases already incubating in the United States as they were. So we're a little bit slow to pick that up in terms of that. And finally, the variants of concern. So again, RNA viruses can mutate, and again, we still, in our waves of COVID, they're being predominated by what we'd say different variants, each with a little bit different opportunistic way of transmission, and that will continue. However, as we see, and we'll talk about more in this latest BA2 outbreak that we're having this wave, a lot of transmission out there, but that's been disconnected with severe disease, primarily because of the lot of immunity that's been built up either through vaccine, prior exposure, or both. And so we're seeing what we call the disconjugation or the disconnection, primarily, again, for most people, between infection now and severe disease. And that, to me, is an important point, and that is the most important point from a public health point of view. These two charts, I think, also highlight, very well in terms of comparing this pandemic to other pandemics that we might have read about or heard about. So this was from a book by Christakis called Apollo's Arrow that was published last year. And so it needs to be updated a little bit. But the arrow shows the effect of transmissibility and severity in blue of the current COVID-19 pandemic. And to the right of that is the 1918 pandemic in terms of influenza. So you can see that it really ranks almost equal with that in terms of severity and also in terms of transmissibility. The curve to the right shows a different story. Although there's many cases, this is the mortality curve. And from an epidemiologic point of view, we say it's got an L-shaped curve, meaning that if you look at age, it isn't until you get up to age 50 or 60 where you really see a significant mortality effect for COVID-19. It's not to say that children or young people haven't died, they have, but the greatest impact in terms of mortality has been with the elderly. Now that is a tragedy, but if we think about it, if this virus was killing children at the same frequency as our very elderly, that would be really catastrophic. The other way we can look at mortality is by something called years of productive life lost, meaning, so this adjusts for whom is getting, whom is dying from this infection and what impact that has on life longevity. So if you look at the epidemic deaths per 1,000 people of COVID-19, it's in the top, followed by the Spanish flu, followed by HIV, which primarily affected young people before treatment, and then the opioid epidemic and overdose, again, biased more toward younger people. When we adjust those killing curves based on what we would say total life lost, you can see that COVID-19 diminishes a little, but things such as the Spanish flu, which did affect children, HIV pre-treatment, which did affect generally a younger population, and of course, the ongoing tragedy of overdose with the opioid use epidemic really is much more disproportional. Now, what about deaths in the U.S.? As you know, we're reaching that figure of about 1 million deaths, which is truly astounding, really astounding and hard to take in. This is last year's data in terms of from 2020. So again, heart disease, the #1 killer in the U.S. of about 3.5 million deaths a year, followed by cancer, but COVID inserted itself as number 3. This year, figures were updated this week. Still the same 3, but there was 80,000 more deaths from COVID-19, compromising about 13% of all mortality in the United States. This is death certificate data, so it's not perfect, but that's a striking amount. Number 4, in both years, was unintentional injuries, and much of that was driven also by overdose deaths. Not all, of course, so a lot of these things are related. When we look at the numbers as to the United States compared to other developed countries, we were clearly at the top, and there's many reasons for that. Some of that is adjusted for age. Some of that is adjusted for obesity, which we'll talk about as a risk factor, and some of that we still don't understand. But there's no question that the U.S. was really hit extremely hard, and I don't think there's any of us that don't know somebody who was directly affected or indirectly affected by this pandemic. This was an interesting article, again, which looked at the issue of obesity. Now, most of us, including myself, can lose a little weight. I get that in terms of here. But it was a wake-up call. And we saw this early on in the hospital in the sickest patients, especially amongst the young patients, that obesity was clearly playing a role. The pathophysiology is still yet to be worked out, but that clearly was one risk factor for severe disease, not the only risk factor. And then this gets to other issues about health and wellness in the United States, and we'll talk more about that in terms of food deserts, in terms of how we get our meals, in terms of another potential lesson learned moving forward. The other impact is that we don't tend to think about, or maybe not up in front and center, is the issue of orphans. Now, HIV orphans we all know about, and we saw that, but globally, if you think about the reported 5 million deaths from COVID-19, that has translated into 5.2 million children who have lost a guardian or have lost a parent, which is huge impact in terms of this. So the orphan rates doubled in the most recent 6 months, even higher. And here in the United States, it's estimated that 200,000 children lost a parent or a guardian to COVID. And that impact in a childhood, as you know, is just extremely hard to replace. Now, this gets to the question of what is the true death rate globally? And I think it's to be determined. There was a report came out a couple weeks ago in Lancet that stated that the reported 5 million deaths is probably underreported by a factor of 3. So places like China, India, which has not reported deaths, yet we know from what we would say satellite imagery that there was a lot of funeral pyres, and so we know that there was a lot of deaths. China, as you know, up until recently has reported less than, I think, 10,000 deaths from COVID-19. That is changing now with BA2 kind of going through China and Hong Kong, and their elderly relatively unimmunized or unimmunized with what we would say a less than ideal vaccine. So those numbers are expected to rise. A lot of reasons why people don't want to necessarily publish this. There's politics wrapped up in terms of leaders. We understand that as well. But on the other hand, again, the estimates are 3 times what is truly reported is probably the truer global mortality. And as we talked about, even in the States, one thing this uncovered early was the social determinants of health, meaning these are things where 80% of health and wellness can be determined by your zip code. Access to food, access to care, wealth, poverty, neighbors, and things, not about your DNA. So this was really uncovered, as we know, here in the States. And even in the most recent Omicron wave, you can see that the hospitalizations and deaths amongst people of color were significantly higher than not. Some of that obviously has to do with vaccines, but also access to care and treatment. This slide, again, not to get technical, but as an ID person, we like to talk about the incubation period, so the time of infection to the onset of symptoms. But again, that latent period for SARS-CoV-2, there's a bigger portion of that latent period where you're infected without symptoms, but you're still contagious to others. And that is really where this has continued to drive and continues to spread in terms of where we see our patients. And although super spreader events get a lot of attention, I love reading the MMWR stories. So whether it's a bar in terms of the bartender, spreading to the drinkers en masse, or many of you heard about the choir practice in a relatively elderly choir in Washington where the attack rate was close to 80%. So en masse singing a prolonged period of time. So these things really clearly do occur. But again, most transmission is occurring in our households. That's where we're spending time en masse, close space, with people who are coming in and out. And again, now with Omicron, it's about over 50%, if you have Omicron in the household, 50% transmission rate to members of that household. So when we talk about vaccine coverage and things, I always look to the family, or it's kind of cocooning in making sure, is everyone at least had that opportunity to kind of think about the risk that they may be bringing into the home. Not that it's a blame situation, but you want to protect the whole household. And as you know, even the Queen herself was infected, probably by her son, in terms of this, and even our Surgeon General, right? And these are people we know are boosted and are doing all the right things. This is just how infectious and contagious now BA2 is, but again, brought in by close family household contacts. In comparing it to others now, if you looked at SARS-CoV-1, which it was about a 6% household attack rate, in the Middle Eastern Respiratory Syndrome, which is another coronavirus, maybe even 3%. So this really does distinguish in many ways why we have force multiplied transmission still occurring in terms of within the households globally. Now, as a clinician, I talked a little bit about we don't want to just get anchored into one syndrome. So again, the anosmia people were turned into, the chilblain tones, the respiratory symptoms. But there's a lot of overlap between acute COVID infection and, say, influenza or other type of how could I say that, other types of respiratory syndromes especially. And there was a good study done in JAMA probably 10 years ago which said that most physicians cannot distinguish between flu or not flu if someone walks into their office. So it's like a coin flip. And so I think I'm an okay clinician, but without Dr. Bosler's team and access to testing, I'm also like a coin flip. And so this is another reason why testing becomes so important in terms of to identify. And again, almost every part of the body can be affected by COVID, and this becomes important, and we continue to learn more and more about that. The other thing is clinical recovery. So early on, even young people who were infected, not hospitalized, a third of them will still complain about a lingering symptom 3 weeks later, whether it's a cough, fatigue, or malaise. So that is probably not surprising, but of course that probably heralded the issue of long COVID for some patients in terms of this, that this virus in some people are going to cause more lingering symptoms. And it's a whole, obviously, a big area of research now is that long hauler syndrome, which we consider to be lingering symptoms after 90 days of infection. There's a lot of money being put into this. The clinic has a kind of what we call a post-acute or sequelae clinic in terms of for management. A lot of study going on, proteomics, blood work, and things of this nature, trying to define who's at risk, trying to define what the pathways are for this, and then potentially treatment. So our vaccine's good for people who with long COVID or not, that is specifically SARS-CoV-2 vaccines. Are there other potential treatments that could be done? Right now, there are no directed antivirals. We do know there are some sequelae, like the postural orthotopic hypotension. So some people can develop POTS, and that's treated with certain medications. So this is ongoing. Perhaps the scariest one that people might have read about last month was a study where they looked at PET scanning of people who had COVID. And this was a cohort that had previous PET scans, and they saw some areas of the brain in some patients light up. These were the areas primarily associated with smell, which is maybe not surprising. So does COVID affect the brain in terms of and what can it do with that? Many of us know people who have been infected that still complain about fogginess and cognitive impairment. So this is another area of active research. The other thing I do want to hop on is the airplane and air travel. Transmission can occur on airlines, but remember, it is the movement of people across boundaries that really helps facilitate transmission of knowledge, but also transmission of other things. We always joke now that you can be incubating, you can be in South America, you can be incubating cholera and land in Newark later that day. And this is how, obviously, some infections kind of declare themselves. We call those in epidemiology peripatetic, where they're acquired in one geographic area but are diagnosed in another. And again, with airline and how mobile we are, it's not surprising. So this, for SARS-CoV-1, it was the first millennium jet disease. And you may, if you remember back then, there were areas that were affected. There was an outbreak in Toronto. It was just by the grace of God that it didn't come to Cleveland, because we would have also been a little bit unmasked about that. And then it went away. Why? We're not certain. But if you look at the case counts, 8,000 in less than 1,000 deaths, which is still a lot of deaths. Similarly, a coronavirus, but clearly different than the one that we have experiencing the past 2 years. And so this gets to kind of my personal lessons and bucket list. And the first is humility. And I know Father Ryan preaches that all the time, the pastor, in terms of this. That is an important quality for all of us, especially in medicine. And that is one, is humility, is knowing what we don't know and being comfortable with that, but also being honest about that. Next is, of course, gratitude. And gratitude to the people we work with, gratitude to the people at home. This is also a kind word, especially during the pandemic, has been very helpful. And then, of course, love. This is the Lover's Wall up in, this is in Cartagena in terms of Colombia. So I kind of like that. I was able to go there with my wife and just appreciate those whom you love the most and let them know you do love them. I think that's a practice that I try to do a little bit more now. The other thing, and I don't want to step on any male egos here, but I think we learned a little bit more about leadership and about how some of the best leaders in the world are women. And I know that's not generalizable, but more and more studies are coming out with this. So obviously PM Merkel is no longer there. Artem was amazing in New Zealand, and of course the president of Taiwan, all very strong, all very measured, and did very, very good policies in terms of COVID. And it's also interesting that if you look at this statistic, in 2020, only 8% of the 193 United Nations states were led by women, and only 6% of our Fortune 500 companies. This is going to change. This has got to change. And I remember there's a famous quote when Bill Gates went to Saudi Arabia once and gave a lecture for the royalty, and the room was divided in half. And someone said, well, why isn't Riyadh going to ever do a Microsoft? And his response was, in order for that to happen, you've got to use all your population. And I think the women kind of stood up and clapped at that point. And the kingdom is changing, too, in terms of here. If you look specifically, though, at women in science in COVID, the fingerprints are all over that. So everyone knows about the Pfizer BioNTech, but that's a husband and wife team, and she is right behind that. So Pfizer's vaccine would not have been developed without a woman. Same thing in terms of the UK vaccine, adenoviral vector vaccine. Same thing at the NIH with Dr. Corbett in terms of Moderna's. And Dr. Carrico, you can see up there, was instrumental. For 20 years, she labored over mRNA where no one really cared, and her discoveries also led to the stabilization in the effectiveness of the mRNA vaccines. Also, I know there's maybe a little controversy, but there's a famous virologist in China, obviously, who studied viruses, bat viruses, including coronavirus, and again, has done amazing work in terms of in this field. And finally, when we go back to the double helix, yes, Watson and Crick got the Nobel Prize, but remember, Rosalind Kirkland was there, and without her discovery of X-ray diffraction, which there's a little controversy, some say was lifted, that double helix would have taken a little bit longer time to figure out. And fast forward to the code breakers, so Jennifer Doudna, who won the Nobel Prize for a lot of her work on mRNA in 2020. So women in science are here, and it's great to see in terms of as they're pushing the fields forward. And for me, it becomes personal too. One of my oldest is a family medicine resident in terms of here, but in 2020, in medicine, we reached the tipping point in U.S. medical schools. More women matriculating in our medical schools than men. And again, I think that's a very, very good thing in terms of as we move forward. And we'll continue to see women continue to rise in our institutions. As you know, at the clinic, our chief of staff is a woman in terms of this. And Dr. Mihaljevic has made it clear. He wants the clinic to be run by people who look like the people who are working there. And I think that is extremely important. The other thing I think for many of us who, with spouses or have daughters, nieces, or nephews, the pandemic also unraveled the other issue, an elephant in the room, and that's daycare. So I always kind of laugh. I mean, I'm a physician. My wife was an attorney. We had 3 girls, and I remember in Atlanta, when anything happened to the girls medically, they'd always call Ann in terms of this nature. They wouldn't call me. And so this is a big deal now for policymakers. We need people in the workforce. Women are a talent. If you want that woman in the workforce, you better pay attention in terms of who's going to take care of the children and invest more in good daycare. And I think companies and things are getting that now. The other thing you see is our birth rate. Our birth rate is continuing to fall like other countries. And without immigration, it's well below replacement rate, which is probably a geo-threat to the country in terms of policy. And if you look at other countries, China, because of their one-child policy, their population is going to fall. Japan sells more diapers to adults than children. they have an issue in terms of a demography issue. And South Korea has the lowest birth rate at 0.9. So these are all things I think that policymakers are beginning to look at, and I think it's going to be very interesting to see how this sorts out. Okay, pivot back to physicians and our failures. So Voltaire was not a big fan of physicians, as you can see by this quote: "Doctors are men who prescribe medicines of which they know little to cure diseases, of which they know less in human beings, of whom they know nothing." So not a very patient experience that we would like. And I think the other lesson we learned in medicine, and again, when you're there, you want to help patients, but our first dictum is do no harm. And sometimes doing nothing, at least not trying something, may be better than that. And this gets to the issue between clinical observation and what I call my clinical skills, which I rate very highly, versus randomized controlled trials, and the need, especially during a pandemic, to quickly sort out what works, what doesn't, and what is harmful. In the US, actually, although we have a great medical care system, we did not have a system that could roll out randomized controlled trials like the Brits to get answers. And most of the good answers actually didn't come from the United States. Part of that is probably because of national health care and other issues. But the point is, this becomes important because failure to understand the pathophysiology, in our rush to do something, we can do harm, and that is not what we want to do. This is a very good book by Judea Pearl, a statistician, just a brilliant mind, and in the book of Why. And this is, he really pushes the issue about statisticians and causality. So most of us in AI now, which I know is all the realm, that's association. That's just the lowest ring of observation. Next is intervention, and next is counterfactual. So to get to causality, you've got to jump through those hoops, and that becomes extremely important whether we're talking about economic interventions or medical interventions. So this has become de rigueur reading for, again, our statisticians and our investigators. On a side note, at about page 220, he says he had to take some time off, I think it was in 2010, 2011. His son, Daniel Pearl, was killed, as all of us remember, in that horrendous decapitation in Pakistan. So truly an amazing family and just an amazing book. This gets to the ivermectin. Now, I've used ivermectin. We use ivermectin in humans for a couple parasitic diseases, strongyloidiasis, which we do see here in the States, and river blindness, which I have never seen. It's also used a lot in veterinary medicine. But this is a very interesting podcast on the Daily that tells the ivermectin story. And it's more than just a drug and a use. It really intertwines, I think, the politics of the pandemic and just how things can go awry. And so it just is interesting that CDC published a study about how many people were taking ivermectin and getting overdoses of ivermectin. Most of that was being diverted through veterinary medicine because of how could I say, disinformation or misinformation. Some of that was self-inflicted. So there was an article published in a journal that was later retracted. That data was all made up. But as you know, the harm can be done. So getting to the point about always humility, what may work, continue to make sure that we continue to follow that down so we don't put into practices things that are harmful. And as a clinician, we saw this bleed into families. Some family members were very, they wanted this drug for their loved one. Not because they were stupid or not because, they wanted something that they felt they heard this could be a lifesaver. And that's the other unintended consequences of bad information or misinformation getting out. Then it puts the clinical teams, kind of potentially in a conflict with the family members who we all want to be on the same side here. And that can be, for a clinician, can also be very disheartening. In terms of treatment, I'm not going to go through a lot of the treatment, but a lot of our treatment in terms of where we interact is where we think the virus is in the immune response. Early on, we talk about viral replication, but this virus goes down in time even without treatment, unlike SARS-CoV-1. And then later in the course, we might be talking about inflammation from the virus, and hence using things other than antivirals for treatment. If you look at our treatments, and this is from the New York Times treatment tracker, I would still say it's been disappointing to date, but improving. We have only one FDA-approved drug, remdesivir, Valkyrie, but that was not designed for SARS-CoV-2. It was kind of an orphan drug. Now, some of the biggest things that impacted life had nothing to do with new innovations. It was mechanical innovation, proning, that is for our sickest patients, putting them in a prone position on the respirator, and using steroids early for the sickest patients. So these were things that were shown in clinical trials. We are pivoting now, as you know, to more therapeutics, whether it's monoclonal antibodies or whether it's now directed antivirals. But in the midst of things, there was not a lot of good treatment except for supportive care in steroids for our sickest patients. In this, I like this kind of Swiss cheese metaphor. We use this in terms of kind of in many different fields, especially in terms of harm in engineering. So we try to put up as many blocks of the cheese to prevent an adverse outcome. Each hole of the cheese is a way for something to get through. So we used personal responsibilities, if you remember, right? Distancing, cover your cough. If you're sick, don't go to work, wear a mask. So that was put in there. And then social responsibilities. I think we all remember when DeWine and Amy Acton recommended, it was the St. Patrick's Day, right before a hard decision to make, and saying, we're closing things down. We're going to close the schools down as well. Tough decisions to make. And then finally, that last Swiss piece of cheese was the vaccine. And the vaccines have been very, very, very good, but the vaccines, as we know, haven't been a panacea, haven't been the magic bullet in terms of here. So we go back and forth, but I kind of like this construct. And right now, I would assess that we're not going to see a lot of what I call state-mandated mandates anymore, that it really is going to go back to personal choice in terms of how we judge our risk, and we have more tools to mitigate as well. Whether you agree with that policy or not, that appears to be the way forward for most states. In terms of vaccine, I love this cover. For those of you who are into Greek mythology, you remember Thetis have baby Achilles. I think she had pissed off a couple of the gods, and so to try to protect Achilles, she dipped him in the river Thetis, and as you can see, he's dipped, except for that one part of his Achilles, the Achilles tendon, which came back to get him later. But this also portrays, because if we think about immunization, that passive immunization of mother to fetus is still around, right? The antibodies from the mother that goes to protect that baby for the first 6 months, whether it's from measles, mumps, and in breast milk. So this is a very good, I think, picture of immunizations, which have obviously progressed since then. And all of us, I think, in terms of equity and equality, when vaccines first came out, really promulgate no one is safe until everyone is safe. And we really promoted and still promote not just vaccines for us, but also vaccines for everybody. Now that program has stalled a little bit for a lot of reasons, but it's interesting to note that about half the world has received at least one COVID vaccination. Obviously, rates in parts of Africa are less than 20%, but it is still an amazing feat, I think, in terms of delivery. We're not done yet. I'm not going to go through all the vaccines except to say there are 2 FDA-approved vaccines, and how you know something's FDA-approved is they have a name. Not a BNT104, but they actually have a name. Now, Pfizer, Comirnaty, I still have a hard time saying that. The RNA's in there. Moderna clearly had a better, I think, marketing campaign. Spikevax is a very cool name for a vaccine, so in terms of this. And as you know, these are the workhorses for the U.S., and again, EUA is approval for now patients 5 to 11 in terms of this, and we're still waiting for that approval for less than 5. There's still a platform for non-mRNA vaccines, and for some things like the protein subunit, it may be used as a dusting. It's got less fastidious requirements for delivery, so it could become the world's vaccine, especially in areas that are hard to deliver. So that's why there's still, obviously, a lot of research and energy in terms of new vaccines as well as modification of old ones. One of the questions, why do we need additional doses? And on the right, I just put up Other examples of current vaccines. So the HPV vaccine, okay, depending on when you get it, you need more than one dose for it to be effective, usually 3 doses in terms of this. And we're trying to get, obviously, those adolescents before the onset of sexual debut for the greatest protection. You might have waning immunity over time. That's why many of you who may be grandparents are told, mom or dad, before you come see baby, is your Tdap up to date, right? Because pertussis, we don't have a vaccine for the less than 6 months old, and so you want to have that bubble, and part of that is to make sure that grandma or grandpa isn't going to spread asymptomatically to that infant. And then again, new strains, and that's our influenza experience, right? Although we get usually four strains in that vaccine, that's modified based on what's predicting and what's circulating. And so that still may happen with the next generations of COVID vaccines. I do want to say, in terms of mortality, that immunity is given both by natural infection and vaccine. For a while there was some controversy. But if you look at the studies, and we've done studies on our own employees at the clinic, but here you can see on the bottom in Omicron, this was, again, deaths, fully vaccinated and boosted versus unvaccinated. The biggest boon there is people who have not, what we'd say, spike exposed. They haven't had COVID and they haven't been vaccinated. And this is where I think the real value of vaccination is protection from severe disease and death. Similarly, vaccine status, you can see that in terms of infection, even those that were boosted still got infected with BA2 and still are getting infected. But the important point is we're not seeing the severe disease. So the numbers now, hard to actually assess in my mind because a lot of testing is going offline. Many of you are doing at-home COVID testing. Some people aren't getting tested if they're not that sick. At the clinic, we have other ways of looking as well. My radiology friends, when we go down on radiology rounds, we're not seeing the severe pneumonia infiltrates either. So I honestly do believe it's not that there isn't, there is this disconnection at the current moment, which is a good thing. A little bit about vaccine immunity. Everyone is talking about, well, can I get a blood test to show that I've got protective antibody? And again, there is no blood test commercially available now that's predictive of immunity. So they're working on that. The other thing is, when we talk about immunity for COVID-19, there's two forms of immunity. There's the antibody response, which actually can be boosted by the vaccine and then wanes. And that's what we think helps prevent against what we call less severe disease or infection. Then there's the other piece of our immune system, the cell-mediated. That's the T and B cell. Longer lasting. This is really where we believe protects against severe disease, and this does last longer. So the bottom line here is many of you may have gotten antibody tests, but from a clinician's point of view, they're not informative and can actually misinform, in my opinion. Finally, we go to disruption, and we felt this in our supply chains. So hospitals were like every other, I would say, healthcare delivery system. We were on that Walmart just in time as opposed to just in case. This went for beds, nurses, supplies. And of course, when you stretch your resources when the pandemic, when we got up on that curve, this really led some healthcare systems to stretch and some to break. And so this was a big lesson. And so when you look about the disruption, obviously some companies were in a better space to deliver what we call corona services. So these are generally the Amazons, the Netflix, the delivery services, to give us different ways as people were standing down at home. And if you look at the curve for Amazon hiring, it's still going on. Hundreds of thousands of new workers for all these fulfillment centers that we see being built up here to deliver all the stuff that people at home or other places were ordering. We also got another lesson about geopolitics, I think. And having been to Egypt and seen the Nile, I was not aware that 10% of the world's global products go through it. And of course, this was a mess. It turned out to be a 5-day mess, but a big mess in terms of what we would say strategic supply. And as you know, I think the Israelis are now talking with Dubai about having another kind of channel to connect the to connect those two seas beyond the Nile. Now, many of you might not have saw this in the news, but this was Easter Sunday. Same company, same grounding, but this was not blocking any major threshold in terms of this. So these things are still going to be at risk as we move forward. And then when we look at, how could I say that the disruption, where are we vulnerable in terms of where Amazon, these places are looking? Well, they go where the money is. And the big disruption you can see in terms of the largest sectors by revenue are where I work, in hospitals and healthcare, but also education. And many of us saw that in terms of how education, how healthcare was delivered. All of a sudden, it was okay to get distance health, telehealth in terms of this. And for many patients, actually, it was desirable in terms of that. So these are really interesting, I think, where we're still trying, how could I say, to kind of sort out, but I don't think this is going to go away. And so we are looking, and we're really being pressed with this. And Jeff Bezos, whatever you think of him, I think he's the second richest man in the world or in America. But his approach is your margin is my opportunity, and they're in the healthcare business. And so you can think about now where someone may be sick, or mom has got a little child with a fever. She gets her test is there, then I get teleconferenced and looked at Junior, and okay, and he either needs Tamiflu or maybe needs another drug, and then Amazon is the one that's going to deliver the drug, deliver the test, and also set up that visit. So this space, I think, is ripe for disruption. One of the ways I think to frame where we went through was also an issue of scaling. So John List is an economist, and he talks about the voltage effects, which is all about scaling in startups. How do you go from a good idea to a small prototype to getting on the shelf at Walmart? And what he points out in terms of if we frame the pandemic response as a scaling challenge, weaknesses in systems are often going to reveal themselves under stress. In many systems, healthcare, education, was stressed by the pandemic. And scalable ideas and solutions are kind of our most valuable response to this, and how do we go about that? And it's not going to be a silver bullet. So as we talked about, there's different solutions now in our armamentarium in healthcare that doesn't require the patient necessarily have a face-to-face or taking out that distance in time, which I think is a good thing. So I think some of the voltage gains during the pandemic was our system response. Dr. Bosler mentioned that. It wasn't just the clinic working with the clinic, but the clinic was working with UH, other healthcare systems, the governor and the sections. We saw coordination that I had never seen before, which is a good thing, learning from each other. Vaccine development and access, I think that's still a remarkable positive. Remote work solutions, not just for healthcare, but for a lot of people. How many people miss commuting? I mean, those are, as we talked about, unbillable hours in terms of this. And stimulus checks. I think that's important too. The government understood that. You don't want people suffering, hungry, or things of this nature. However, I do think there were some other things that kind of were not very good. Messaging, including messaging in healthcare. As I go back and look at some of the messaging, you need messaging that is clear, and you need messaging that is a conversation. I think one of the best messaging we saw here in Ohio was Dr. Acton and Governor DeWine. The cadence was almost daily. It was almost like inviting them into your household, so you got to know Dr. Acton or Governor DeWine. It wasn't just once a week or once a month. There's a relationship that was built in a cadence. The press was fed, the public, and they could say, we'll get back on that. And they did. I thought that was very effective. Where was CDC in messaging? I love the place. I worked there. That did not occur. You did not see the head of CDC having the same type of relationships in terms of this nature. Dr. Fauci was there, but Dr. Fauci's not speaks for CDC. The policies were being made by CDC. He's more NIH basic science. And I think there's a lot of reasons that didn't happen, but that was a failure. Contact tracing. didn't really work well in America in terms of this. Confusion over what is an exposure? What does this mean? Do I have to stay home? I know all of you now know the difference between isolation and quarantine, but that's still misused. And so we didn't exactly do that well. One might argue you probably really can't do that well in a democracy like ours, although we could quibble about that. Home testing in the Omicron wave. When we think about the last holidays, okay, we want to go see grandma or someone's here, I need to get a test. Well, you can't get a PCR test because all of a sudden there's no room at the end, there's no appointments. And we did not have the lateral flow assays like Europe had, now that all of us probably have in our homes. So that was a miss in terms of that. And then prolonged school closures. My kids are out of school, but I saw the neighbors, and I just can't imagine a 3, 5, the children, we'll talk more about that, but that had a huge effect in terms of our kids, which leads to mental health treatment. So this is for Dr. Bosler. Testing was crucial because my clinical skills weren't good enough. And so we learned a lot about testing and test capacity and still are doing so. And I think this is a breakthrough. And I do see in the future, you're going to have more testing done by patients at home in out-of-hospital situations, not just for COVID, but for other things. All of you hopefully ordered your testing in terms of this nature, so it's in part of your area, because right now you never know. Do I have it? Do I not? I want to test myself. It just can take the air out of the balloon, and I think it's a good thing to have. And this was an interesting ad, right before the Omicron outbreak, but it shows a father, which I think is good, looking after the daughter who's clearly sick, and then in the background, this was done by Cepheid, which is a company that does testing. But you can see where this can go then, as I talked about. Testing can be done right there. If it's a positive test, I can get telehealth or message, and if I need to prescribe something, it can be done without moving the child or inconveniencing the parent in doing it. And I think that's a big, big win. The other thing I want to talk about, we talked about information, and when we submit articles in medicine, it's peer-reviewed. You submit it to the journal, there's a waiting period, you get the feedback, and it can take months to get something submitted to it's accepted and then in print. This changed in COVID-19. First of all the journals became open in terms of not having to pay to look at the articles. But where we were getting our information was either the New York Times, the Wall Street Journal, about articles, or people submitting their pre-publication manuscripts up online. So this is one that we did in terms of this nature. When we talked about, this one was necessity of vaccination in previously infected individuals, submitted up online on MRV Rex, and boom, you get instant feedback and instant uptake if it's very good. We subsequently have published on this in the routine process, but that takes a lot of time. And so this is disruptive for I would say the journals, but it's very, very effective, and I don't see us going back from this either. So at the clinic, in all of our places, we learn this in terms of disaster planning, that preparedness is a continuous process. React, respond, recover, know who's in charge, so this is the command and control, and then communicate even more. And this was very important for our healthcare system, and I know other healthcare systems. So some of the lessons in particular to the healthcare space, there was a healthcare dynamic that Dr. Bosler talked about, that healthcare workers could get infected. And are you protecting your healthcare workers? Because the healthcare workers have to be sure that they're going to be protected and their families. It's hard for them to deliver care if he or she has that fear. Not all healthcare facilities were resourced equally. I was fortunate to be at the clinic. We have tremendous amount of resources, a tremendous amount. But like I said, my daughter was in a smaller hospital outside of Boston. She had one N95 to wear all week. And so you saw that even in America, very quickly, there's discrepancies in terms of this. Gaps in implementation of infection prevention, some confusion there. And again, once the healthcare workers, if they feel that you don't have their back or not taking care of them, then the system can really tumble quickly. And so again, some of these things, and I credit the leadership at the clinic, They were present, not hunkering down, candor, so you make a mistake or a decision. It was very transparent, fast, inclusive communications. And I like this other one, is be more compassionate than you think you need to be. People really do, the ones showing up, need those hugs or just the hellos. The other format that we tried in our presentations, what's the why, what's the tasking, what's the way forward? It's kind of taken from the military in terms of this, so that the communication is clean and pithy, even if it is being over Zoom. And again, for the hospital, transparency. I think that's the best disinfectant. I think William Brandeis had said that a long time ago, but this becomes important for us. As in the pre-talk discussion, someone was talking about reading the premonition, so there's a lot of good books going. I'm a big CDC fan, so I'm not gonna be kind of hate on the CDC, but there was a lot of potential lack of funding, a lack of authority. The politics did get mixed up in there. They don't have a unified, what I call systemic database or computer system. We think of CDC as this, like NASA type of project, and it's very good, but underfunded. And as some pointed out, this really was hard for them to scale up to in terms of all the different fronts here, in terms of here. And even at the local level, this just shows you the diaspora that each of the 50 states, as you know, has their own ability to make policy. CDC advises on some things like the cruise ships or the mask mandates. They can reach out with executive orders, but they don't really, they advise. And as you saw, each state could have it, and did often have different policies, which makes it confusing for the population. And I think that really hinders things. On the other hand, be careful what you ask for. If we empower CDC to go to facial recognition in all the information, you might end up like a place like we see in China today. And many have written that China is using the COVID-19, SARS-CoV-2, in terms of the facial recognition for more political reasons. Because if you go to China, yes, if you test positive or exposed, your travel thing may turn red, but your travel thing may turn red for other reasons. Maybe you posted something that was not politically in favor of. Americans will not tolerate this in that regard. Most of us really our individual rights, household rights, we hold to ourselves. So in terms of forecasting, I've learned early on not to predict. So will we reach herd immunity through infection and immunization? By many estimates, we're already there. It's estimated at least 50% of Americans have actually been infected or exposed to the most recent Omicron BA.2. We know that our vaccine rate is about 60 to 70%. It's not great, but a lot of people have had vaccine. So I do think, as I said, we're seeing this disconnect for severe disease and infection now because of the archived immunity. It's not to say that came without a cost. We talked about the 1 million dead, and not to mention the people that obviously have sequelae from the COVID. The pathogen will evolve to become less lethal. That is probably happening as well. BA.2 is still something to be reckoned with, but again, I can't tell you it's all because of prior immunity that it's less invasive. It does attack a little bit different part of our respiratory tract. The data where we're really going to see that is going to come from China, as I said, because China has probably one of the last places where you have a lot of people that have not had natural infection that are vulnerable, like they're elderly. And MMWR reported probably last month in Hong Kong that they had the highest death rate in the world at the time, in part because elderly people probably getting Omicron that were not vaccinated with mRNA, and in fact not vaccinated. So I wouldn't say that BA.2 is necessarily, I still wouldn't advise getting it if you're not spike exposed. Will the pathogen disappear? So SARS-CoV-1, as we said, did disappear. The challenge is this is what we call a zoonosis. It did come from animals, and we've never been able to eradicate a pathogen from humans where there's a non-human reservoir. The smallpox does not circulate in animals. That's the only human pathogen we've been able to eradicate. Polio also doesn't circulate in animals, but we're not there yet. So I wouldn't bank on coronavirus going away. And as you know, it's been found in deer, it's found in ferrets, it's found in cats, it's found in chimpanzees. So it's in the animals as well. And we could be evolve to become more resistant, but I wouldn't want to bank on that either. I'll be, that's not a way forward or a durable way forward. But it's hopefully where this will evolve is for most will be an annoying seasonal coronavirus like the other 4 coronaviruses that cause respiratory. It doesn't mean that some people still won't die from it, but that the next wave, as we continue to move forward, it will be reduced more to an influenza mortality than what we saw the past 2 years. And this gets to, I think, the ambiguous closure. And, I've been reading a lot in terms of the myth of closure. And, this is very important because most people say, well, get over it. You've had enough time, whether you've lost somebody. And the new paradigm is there is no timeline for grief. And I think if we talk to Reverend Ryan, he could write a book on this and see this. It's in our individual way of doing that. And it's interesting, the American Psychiatric Society just acknowledged a new DSM criteria of prolonged grief disorder, which is what they would say a persistent feeling of not just depression, but just grief that lasts over a year after the loss or a tragedy. So I think we're becoming more inclusive about what health means in America, other than just physical health, and this has had a huge impact in terms of our psyche. This report came out 2 weeks ago. It's an interesting read. So this is CDC. They did a survey of 8,000 high school students in 2021, and they went to different domains. They went to domains about substance use. They went to domains about feeling depressed, about persecution, also about abuse at home, not primarily physical, but emotional. And the data from this is astounding when you read it. A third of adolescents self-reported a feeling of hopelessness. 20% suicidal attempts, 20% suicidal ideation, 9% suicide attempts. That's huge in terms of our youth. Not so much substance abuse. The big substance abuse is still alcohol. Second was electronic tobacco products. Third, I think, was marijuana in terms of this. And the kids that felt more connected at home or school had less of these issues. When they talked about perception of prejudice, Asian American adolescent schools highest at 60%. Probably some of that from some of the rhetoric around China virus and things of this nature. But very, very interesting. This is our future. We really need to double down and learn more. And if you look at the front page of today's New York Times, it's all about the crisis of mental health in our adolescents. And this is just some of the things that manifested. This is the tick-tock-tick. So a lot of adolescent girls were presenting to ERs with tic disorders, and it almost went literally viral in terms of this. OCD, obsessive-compulsive, anxiety. These are things that, as a parent, your heart would break in terms of watching this happen to your children. And some of this pre-existed the pandemic, but it's clear that this really, really stressed with our adolescent angst. So it'd be interesting. Most of us read. I'm blocking on the book. But anyways, it's hard to be a kid. I think it's very hard to be a high school student to stay in terms of here. And this gets to what can we do or help our patients and our kids? And, we go back to Viktor Frankl, whom survived the concentration camp, and he made the observation it wasn't the strongest or the well-fed or whatever. It was those with hope that actually had the best chance of survival. And how do we pivot from the anxiety, from the depression to hope? How do we help our patients, our family members, our kids? And this, I think, is very, very important for our mental health providers to move forward, to help us all in terms of look forward and hopefully with more hope. I'll end with just where we are. Like I said, CDC kind of changed our red, green, and blue, so now we're still green, although our cases are going up in this regard. Our capacity, our hospital capacity is good, and the number of patients hospitalized with COVID is down, so that really what drives this in terms of green. And again, masking, or what now is being called, I think, kind of a mask uncertainty, I think where this is evolving is take the stigma away. If people want to wear a mask, let them wear a mask in terms of this, that there's many reasons why people can wear a mask. Our transplant patients were wearing masks well before the pandemic for respiratory issues. There's a good amount of people that still feel very uncomfortable going indoors wearing a mask. Let them wear a mask. Don't stigmatize the mask. And as we talked about, in schools in respiratory season, masking should be probably considered to be okay and de rigueur. One of the things that dropped was influenza, actually, admissions and deaths during the pandemic. That's one positive. And some of that is, of course, travel, international travel was down and distancing was down, but also, obviously, I think people were very cognizant about respiratory hygiene and masking. Test positivity we talked about. In terms of vaccinations, so full disclosure, I've gotten my second boost, but again, I'm fully prepared, I think, to have what I call, I hate to say a breakthrough infection because that makes it sound like it's a failure. I feel very protected against severe disease and hospitalization. And I still recommend, the Israeli data is pretty suggestive, people over 60, get that second boost. I'm not talking about immunosuppressed, that's completely different. They should not only get boosted, but we also have a monoclonal antibody that lasts for 6 months for those patients who may not respond to the vaccine. For the children, I think it's going to be interesting. As you know, if you look at vaccine rates, our 5 to 12-year-olds where there's a vaccine available, it's about a 30% uptake. Even when the less than 5 vaccine comes out, I'll be surprised if that uptake is any higher and possibly lower. First of all, it's 3 jabs. Second of all, many of the kids may have already had COVID in the household, so to speak. But I will endorse, obviously, the parents will talk to the pediatricians to get advice. So my daughter, I know, my grandson, he's going to get vaccinated. That's her choice in terms of this nature, even though she did have COVID. Only thing I'll talk about the mask, the cloth is better than nothing. I think that's good. Procedure masks, which I see are actually good if they're tight-fitting, so that's the most comfortable. You can breathe through those. The respirator, the N95s, first of all, you need to get fit tested or they're really not going to do much for you. And they're hard to breathe through for a long period of time. That's why they're respirators in terms of that. One mask I wouldn't wear, don't wear these. This has that outlet valve, so that's not going to do anything in terms of here. So there's a lot of obviously, there's been a lot of money in masking. Again, the government is pivoting toward preparedness away from what we'd say just the pandemic, appropriately so in my mind. We got other things on the front pages these days. And so what they want to do is preparedness, empower, and then good surveillance. This is the president's national preparedness campaign. Surveillance is a part of that. Vaccine is a part of that. Test to treat's a part of that, all which I think is very good. One of the interesting things is we're looking at is wastewater. Who would have thought sewage? And of course, for those of you in Cleveland Heights and in Shaker Heights, we pay a lot of, sewage recovery is a big deal. I know that in terms of this. But it actually turns out to be a leading indicator in terms of potentially coronavirus and other things is what's circulating. And it doesn't require people to have access to health care or a test. The only caveat is it's not just human RNA that could be measured. And so there are other animals, obviously, that could get infected that can contribute to that. But nonetheless, I think it's very novel, which has come out. And this just shows that in New York City, they found strains of coronavirus based on sequencing in the wastewater that weren't in humans. And they speculate, not surprisingly, that it's probably coming from the rats in New York City, which there's a lot of rats, the 4-legged ones. Okay. This won't be our last spillover, and this gets to, I think, preparedness in terms of this. So I do think that we can't afford to continue to be just focused on humans. We learned this lesson with West Nile. We learned it with SARS-CoV-1. What happens in animals is just as important as what happens in humans. And these are some of the lessons. And as you know, there's active surveillance in a lot of animal populations. The most recent one is migrating birds. So there is another pandemic going on right now. It's pathogenic avian influenza. So for those of you that went to the zoo recently, they took all the birds and put them inside to prevent contact, especially from the birds outside or humans. For those of us in Shaker Heights, there was a kill-off of the geese a few weeks ago, which was confirmed to be the H5, the pathogenic avian influenza. So these things are happening, and there is good surveillance for that. I learned reading through this, it's the dappling ducks, that is the ones that stay on the surface, as opposed to the diving ducks where most of the surveillance is done. The danger is this may get into some of the commercial poultries that raise the turkeys in Minneapolis or the chickens. So they are very, very good about biosecurity there and trying to keep this away from those types of flocks. So will we experience another wave? As I said, masking and distancing no longer really in play in terms of coming from top down. Immunity, I do think, is there. In a recent study from South Africa, showed that it was probably baseline prior infection that kept a lot of severe disease away in that population that was only about 33% vaccinated with Omicron. As I said, at least half of us have already been infected with Omicron. You can consider that to be almost a boost. And again, our focus is really on the most vulnerable, the immunosuppressed and the elderly, to try to protect them as much as possible with boosting and or masking. And unfortunately, you know, the other run on a medication was potassium iodide. You know, something that, you know, I grew up, and many of you may have in my elementary school. We all did the drill. We went under the desk. I don't know what that would have done if there was a nuclear blast, but this is, you know, I thought we were done with this. And it's unfortunate in the world we're in today. You know, there's many other things that are on the front plate in terms of, I'm not saying they're more serious than the pandemic, but things that we begin to think about. So I'll end with this. I mean, I've always taught this from, you know, where I go to worship in terms of this. Things that matter, things we can control, trying to always get myself into that middle one. I was blessed to have a grandson born during COVID-19. I think that was my Prozac in terms of here. And so with that, I just thank you for your attention. And
Doctor, you mentioned some widely circulating misinformation at one point or another in your talk. Do you have any idea for actions which are not being taken which might reduce the misinformation that circulates in our country?
yeah, so I think that's a great question, and I don't have an answer. I must admit, I was taken aback by this because, you know, you think, okay, this makes sense to me or from a medical point of view, but this is one lesson that I think we all learned in this pandemic is messaging is important, your audience is important. You know, the former head of the NIH who stepped down said that this is something the NIH is now going to spend some money on because, as we all know, you can be right, but you may not be effective. And so part of this is in any group is getting to yes, and clearly I think medical science and physicians, we didn't have the right messaging, and I don't have that expertise, but I respect it now, and maybe we need to get better on TikTok, maybe we need to get better on our tailoring it to our audience that we want to get to, but we did not have the correct messaging. So I don't have an answer to that, but if someone does, yeah, that's fantastic.
Another question that comes up asks about the concern with the recent outbreak in China. Is there something that makes their vaccine less effective? And are they retooling or boosting their population?
So thank you for that question. What I know about China is what I read. I have no intel. China has at least 2 vaccines, and one is an adenovirus type vector. There is data published on that. But, and they are approved by WHO, so I'm not going to dismiss those vaccines, but clearly they're not necessarily as effective as some of the mRNA vaccines, at least based on data that it came out of Hong Kong. What China is doing, I think, is going to be difficult to continue, the zero COVID policy. You can see the strain in some of the clips. I can't imagine, 3 weeks again, 20 million, people in terms of this. They, I think, are also under the fear. They don't have the number of ICU beds that say we do in the States. And if they project out the worst case scenario, that's a lot of potential people that require hospitalization. So I don't have any more readout on that situation, but we're watching that carefully because, like I said, that will give us a hint about BA2 and severe disease. And unfortunately, I do think you are seeing more reports of death, and it can have a terrible effect on the elderly and immunosuppressed in China.
Thank you. Question about Paxlovid. Is it any good in preventing long COVID, in breakthrough infection, and is it advisable to pack Paxlovid for traveling abroad?
Okay, so let me unpack that. So Paxlovid, just to level set, we have 2 oral antivirals that are under EUA, that is emergency use authorization for treatment of COVID. Paxlovid is the Pfizer product, and it's a combination drug. It's actually combined with a drug called ritonavir, which for those of us that treat HIV, it's got a lot of interactions, but helps boost the primary product. So it is an antiviral. The study that was published on Paxlovid, which just came out in the New England Journal, looked at a very specific population. These were people that I say were spike unexposed, no vaccine, no prior history of COVID, and they were treated within 3 days. And those people did significantly better in terms of outcome, hospitalization, and severity than people that got placebo. So the drug does work. And we are giving it or prescribing it to patients with breakthrough infections or non-breakthrough infections that are at high risk of developing severe disease. It's one of our 3 options, or 4 options. The other is the Merck drug, molnupiravir, which has less interactions, but it was less efficacious in the study. The third is you can still give 3 days of IV remdesivir, but that's 3 days of IV treatment. And then we also have a monoclonal antibody that we can infuse, and can be infused within actually a minute and watch for an hour. So those are our four treatments now for patients not requiring hospitalization and that are not sick. So I would talk to your individual practitioner about taking for travel. Depends on what your conditions are in terms of this. That's not necessarily a bad idea if you're at high risk and you need to travel, in my mind. But I would only do that after consulting your practitioner. And we're just going to have to wait and see more data on that. I've prescribed it probably 10 times. It's you take it twice a day. I think it's going to be 6 pills twice a day. It's over a 5-day period. So it's tolerable. You have to stop your statins for that time and some other drugs or interactions. But generally speaking, it's well tolerated.
Thank you. This question asks you to talk about the importance of slowing the early spread of a pandemic, to learn about the disease, develop treatments and vaccines. And I remember much talk about flattening the curve in the early days.
So another great question. So when we look back, as we said in this, it's true that SARS-CoV-2 was already here by the time we even began to stand up our command and control at the clinic in February. For those of you that read premonitions, there were people that thought about that, and CDC has a flu surveillance, which they collect isolates from different parts of the country. One of the investigators wanted to test for SARS-CoV-2, the isolates that weren't for flu, and there was pushback there. Obviously, hindsight's 20/20, but I think it all makes sense now. But even as I said, we were taking the travel histories, in knowing how connected the world is, it should have been apparent that it wasn't just in China, even in February of 2022. Having said that, what would we have done differently? Well, the other issue was testing, right? I mean, you needed to have an act of God sometimes to get a test. You know, it was almost like because the testing platforms were being reserved appropriately for the sickest patients or those coming into the hospital as opposed to the outpatient. So I think what we've learned now is some of these platforms for the at-home test, not just for COVID, but for flu, for RSV, these things hopefully will be pushed more outside the hospital into the home for early detection. And then in terms of vaccine, I do think that was an amazing, from that isolate, from the sequence that was put up by the Chinese until both Moderna and Pfizer got that and put that into arms in terms of phase 1 and then phase 2 and phase 3 trials was incredible. Perhaps to that first question, our messaging on vaccines needed to change, because people like me, when I got my vaccine in December, I remember it, I almost cried of happiness. Because I was fully anticipated that I was going to get COVID in the hospital. It just, just because of the environment, so to speak.
Another question: has the medical community measured the student learning lost from a year and a half or maybe more of remote learning?
Another great question. In medical school in general, it's interesting because as a medical student in 1980s in New York City, doing my clerkship, I was, it wasn't called AIDS. It was, in fact, at New York Hospital, it was grids. And as a third-year sub-intern, I was the one drawing blood and blood gases without gloves or anything else. So we were kind of put in the forefront there, which was a great experience when I look back. It actually influenced me going into infectious disease. Probably wasn't the safest thing, but then those practices weren't evolved yet. Fast forward to 2022, that's not how we treat our medical students now. In fact, they weren't allowed in terms of to interact with known COVID patients or things that they didn't want to, at least until the vaccine was delivered, which probably was okay. The effect on the learning, I think, is going to be good. I think one thing in medicine is you can catch up pretty quickly in terms of the following years. And there's already a push to shorten medical school and residency to attract more like a European model because of the shortage of physicians. So I think they'll catch up. I think they'll all remember this experience, similar to, hopefully in a good ways as well, that it's something they'll be able to tell their kids and grandkids as well. And hopefully be smarter about it than maybe how we were.
Question for the future. Will the annual flu vaccine include coronavirus component?
Yeah, another good question. So when we think about flu, for whatever reason, at least for the most part, is followed seasonality, right? In austral areas, their winter, our summer, so we kind of look at what's circulating in Australia and parts of China and then predict what comes here. And it follows a pretty regular pattern, although it's not always regular. If you remember the pandemic influenza in 2009, that occurred in April. But coronavirus hasn't settled on a time yet. Right? These waves are coming boom, boom, boom. So we don't know, at least I don't know, is it going to settle as a respiratory virus in the winter, or is it going to continue to kind of pick and choose its pathway based upon the transmissibility or the variant of concern? That becomes important for production when you think about it, because influenza platforms, although they've changed in good ways, but the strains are usually picked by March for delivery as early as August or September. For coronavirus vaccine, we're not there yet. Platforms are not universal, and we don't know where it's going to settle. The other thing, I think, to stay is we don't know what a failure of the vaccine looks like at this point either. So FDA is looking at what does that mean? How do we know when our current products are going to fail for severe illness and hospitalization, not infection? We know that they're not great on prevention of infection, but they are very, very good still for obviously preventing severe disease and hospitalization, which I think is the best endpoint. So to be determined. The companies both are looking at, we'd say, polyvariants, or having more than one product in their vaccine, and the ability to combine is probably also being looked at.
And this is the last question that I have at the moment. So are there ongoing genetic studies as to why certain people had varying levels of severity to COVID-19?
So another great question. So there are, I mean, there is no, what we would say at this point, gene that, or SNP that's been identified that's been associated with a certain, race or things of this nature. But there are work being done, and I presented one of those slides in terms of, especially for the long hauler, to look to see is there any interaction between proteomics, genomics, and host response in terms of severity of symptoms or predicting who may be at risk for a severe outcome. Right now, it's just really clinical. Age, so someone old like me, someone chunky like me, and someone who may not be vaccinated or not spike exposed, we'd be worried about other underlying conditions. So I think these are all things that are going to be continuing. We're going to see more reports on. My approach is, at this point, in terms of some of my decision-making for getting the booster, is I could have waited to see what may come out in the fall or not, but right now, this is what's available. They're very safe in terms of my experience. I mean, you might argue if you're young in the 20s getting another one for the potential risk of myocarditis, you might, that's a different conversation to have with a practitioner. And now I don't have to think about at least the booster for another 5 to 6 months. And so.
Thank you so much, Dr. Gordon, and we're out of questions.
Thank you.
I have a number of thank yous on behalf of the William Birkett Williams Memorial Lecture Committee. Thank you to Pastor Ryan, David Bosler, Jim Dakin for their involvement in the program today. Thank you to Joyce, member of the committee, Joyce Pope, who helped organize ushers at the various doors and did other things to help with the programming. Jeff Barnes and Carl Hoffman, who handled the Q&A. Christine Winters, who is Fairmount's communications manager, and she helped to manage a lot of the varied publicity and coordination of many details. Another member of the committee, Kate Mcfadden, was not able to be here today because she is on the confirmation class retreat. She has been diligent about attending and all the planning meetings, but just couldn't be here. But finally, an enormous thank you to Dr. Stephen Gordon for his informative, timely, and excellent presentation. Please stay tuned, everyone, for the next William Birkett Williams Memorial Lecture, which will be on Saturday, June 4th at 2:30, and the topic will be racial reconciliation. Lastly, I would like to thank the attendees that are here today and those online for joining us today and for providing such thoughtful questions. Thank you.